All right. Hi there, everyone. I'm hoping that this is working. This is my first time doing Facebook Live. So we'll see if it's working or not. I'm just going to double check. Just bear with me here. So I'm really glad that you're here today. And I'm very excited to share some cases with you. I think they're going to be a lot of fun. I really hope that you enjoy them. So if we haven't met before, my name is Dr. Karen Trainer. I am a veterinary pathologist and I specialize in dermpath. I run Innovative Vet Path. I'm based here in the Kansas City metro area, but I work with clients all over the country and internationally as well. I love, love, love dermpath. I love sharing cases and seeing other people's cases and teaching. And so I hope we'll have some fun today. I hope you've used this time to grab something to drink. I've got my hot cocoa here. So I hope everything's going well. I'm just going to trust that this is working, and if not, then we'll just try it again. So what I'm going to do is I'm going to pull up some slides. I've got some slides that are scanned, and then I've also got some like a PowerPoint that I can show with some gross images that go along with the cases. So we'll just give this a shot and see how it goes. I don't know if I'll be able to see your responses in real time, but please do comment or send a message or anything, and I promise I will follow up with you once I figure out this technology. So thank you so much for your patience and bearing with me. All right, so let's see, how do we start this? I'm going to share my screen, and let's start with what do you guys feel like seeing today? Let's see. We've got this here. I'm gonna figure out how to get this. I apologize. This is a lot of new technology for me. I practiced this a bunch of times, but clearly not enough. Okay. So if I share, I'm so sorry. Everyone's watching me bomb. Okay, there we go. All right, so I'm going to show, here it is. This is it. Now, I hope you guys can see this. Let me move these on over to dermpath. All right, let's pull up some slides. All right, so how about we go over a really cool case. This is one of my very favorite cases submitted by one of my very favorite clients. They're all my favorites. But I knew this was going to be a good case. This dog's name is Aggie, and it was submitted by a dermatologist, and I knew it was going to be good because he wrote to me and he said, "Oh, Karen, I've got a good one for you." And he always sends great cases, but when he said that, I knew it was going to be extra. So I'll show you a gross picture afterwards, but let me just set the stage a little bit for you and tell you a little bit what's going on. So, all right, we're at low power here. This is an H&E stain slide, and we've got some tissue you can see from low power. You can already tell we've got some non-haired skin and then some haired skin, but since we're not doing this as a mystery slide, I'll give you some of the history. So this is from a 6-month-old dog, female spayed, beagle mix. The owner noticed that she had pads were peeling off in circular areas, causing some ulcerations on the front feet, but not the rear feet. She had a pinpoint ulcer and at the crease of the elbow, and then also the medial aspect of the left ear. Also 2 small areas of erythema Also on the elbows, the feet were painful. Also, the other dermatologist at the practice saw one of another pup that was a litter mate that also had similar lesions affecting the mouth. So some ulcerated lesions in the mouth. With that history and signalment in mind, we'll take a look at this case. So already at low power, we can see we've got the paw pads here. And so these are non-haired skin. We can see some of the glandular tissue. This epidermis here is pretty well intact, but really most of the excitement is up in these sections here from the haired skin. So if we take a look at these already at low mag, you can get a sense that something's not quite right. So normally when we have skin, I try to use some of my daughter's toys. These are actually mine from, I won't say when, I guess the 80s. I guess these would be considered vintage. But I put this together to just try and show you some of what the normal structure of the skin is. If these orange things here, like the basement membrane, and this is your basal layer of keratinocytes. And then as we progress up through the layers of the epidermis up towards the stratum corneum, we have our stratum spinosum and granulosum. So this is like the normal progression, and it's all attached pretty securely here to the basement membrane. If we were to take that off, then it would be lifted away and we would have a space in between. And that's what we're seeing here on this slide. We're seeing a breakage. We're seeing this space in between this layer here, the epidermis, and the basement membrane. There's that gap. So we can see it's lifted away, and this can be something of a diagnostic dilemma when we're looking at histopath slides. Many times when slides are prepared, they're fixed in formalin, and then they get bisected and then embedded in paraffin wax and then cut on a microtome. And through all of this processing and sectioning and staining, there can be lots of changes that happen to the tissue. And as pathologists, we have to determine, okay, well, what's a real change and what's due to pathology and what's related to the lesion. So something that we can see is detachment of the epidermis from the underlying dermis. And sometimes that's real and sometimes that's artifact. And we have to determine, make a decision if that's real or not. So that's part of why it's so history for the students out there, interns, trainees. Make sure you always give that really good history to the pathologist, and don't just submit it to the pathologist as a mystery slide, because it can just take them a lot longer sometimes to make that interpretation. You'll get better results and faster results if you give them that information, and then they can put that all together in context to help make that determination. So with all of that in mind, as we take a little bit closer look, we zoom in here, we see that in this space, this clear space that we've got, there are some strands of fibrin. There's maybe a couple of erythrocytes. We'll go a little closer. We see a couple of leukocytes in there. So this is a very small amount, but it is inflammation. So if we have something that is occupying that void, that tells us when we're looking at the slide that this is real and not artifact. Sometimes you might also hear of a term called usable artifact of Stenard. I can show some other examples of that another time. I've got some that we can show and discuss and talk about. But as we cruise along, like, this is really what jumps out, is just this clear space that's dissecting all along. And then what's happening in the dermis underneath, this is another clue. So this is part of the circumstantial evidence that we all use to put together in context, is this change real or not? So what's happening here in the dermis is we've got all of these blood vessels, and these are all lined. These are endothelial cells, and some of them are a little bit plump. They're bulging a little bit into the lumen of these vascular spaces that contain the erythrocytes, maybe a few eosinophils, maybe a couple of neutrophil. So what's happening here is we have all of these blood vessels, and you can see how they're almost oriented perpendicular to the epidermis, to that surface. That's a classic feature of granulation tissue. And there's some mix of inflammatory cells. We've got, if we look up close here, get up close and personal, we see maybe some plasma cells with a little bit of perinuclear clearing. We've got maybe a few lymphocytes, a couple of neutrophils here and there, a mast cell. Sometimes it's not so important to worry about every individual cell's identity, but just the general trend. So we have a mix of inflammation in the granulation tissue, and then this really dramatic clefting all along. Just the epidermis is just completely separated from the overlying dermis. So that gets us into the category of some sort of bullous type of lesion. So you start thinking about in your mind, well, what are all the differentials that fall into this category? We can see the epidermis up above it looks pretty, not completely normal, certainly, but we're not seeing individual necrotic keratinocytes with satellotosis the way you might see with erythema multiforme. We would expect to see transepidermal apoptosis of keratinocytes with lymphocytosis. We're not seeing inflammation targeting this interface here. So it's not an interface pattern. So that does help us get to the category of bullous diseases. So it's a young dog. We know that there's a littermate affected, and we have this bullous lesion. And I think we've got enough evidence to say that it's real. So in some areas, while for the most part, it's sort of unzipping from the dermis right along here, we've got like, okay, so there's a little cluster of basal keratinocytes there. So if we're coming back to this analogy with the blocks, and we've got, say, our basement membrane, we have this portion here, the pink are the basal keratinocytes. We've got a couple basal keratinocytes hanging out, still attached to the basement membrane, this orange piece down here. If they were all lined up and say we saw this cleft running along and we had just these little guys hanging out like this, this would be the tombstoning of the basal cell layer, and that would point us to something like pemphigus vulgaris. But these are not very consistent. There's just a little patch here. Not every case reads the textbook. We've got a little bit of remnant of the basal portions, basal layers down there. So we have this beautiful clefting. So this really brings us into the category of, say, well, what about epidermolysis bullosa? So here again, another example where we have the unzipping happening here between the epidermis and the dermis, but then it takes sort of a jagged turn and then it goes right through mid portion of the epidermis. So certainly that can happen. And then on the surface here, we have a bunch of serocellular crust. That's not quite so exciting, but what's important to note is that we're not seeing a ton of acantholytic keratinocytes. And those I would describe more as like these rounded up balls. So instead of having like our nice, neat, orderly grid where everyone's fitting together and has somewhat angular shapes to them, like our normal keratinocytes do, acantholytic keratinocytes, they just become individualized, the breakdown of those desmosomes that connect the cells to each other, and they become shrunken up, rounded, and usually brightly eosinophilic. So we're not seeing a lot of that type of action. So epidermolysis bullosa becomes the most likely differential here. And so then there's different forms of epidermolysis bullosa. You have junctional or dystrophic. How would you tell them apart? So that was the really exciting part for this case. So I've got a special stain to show you for this one. And it's a PAS stain, if I can find that right here. And so I'm going to pull that up. So this is our PAS stain. So back just again at low power, we've got our paw pad sections, and then we'll come back over to the haired skin because this is where it's most dramatic. And so what we're looking for here is the PAS stain is going to highlight the lamina lucida. Now that's part of the basement membrane, these longer pieces here. So we want to see where the lamina lucida is hanging out. Is the lamina lucida, is it stuck to, say, you know, on the top portion? Oops. Is it stuck to the top portion of the cleft, or is it along the bottom of the cleft? So that's what we're looking for, to make the distinction between epidermolysis bullosa, the junctional form or the dystrophic form. I apologize for all of the awkwardness today. So anyway, we'll take a look, and we're going to look for the really brightly eosinophilic line with the PAS stain, and we're going to see, is it on the floor of this bulla or is it on the roof of the bulla? And if we zoom in here, we see this bright pink delicate line, and it's paving all along the floor of this defect. So this tells us that it is junctional epidermolysis bullosa. So this is very exciting, very interesting case. I can't remember the last time or if I had seen this before, or maybe I missed it. But it was very exciting. So we'll cruise around, we'll take a look at some other locations where that pink is showing up. So this pink material here, this is all fibrin. And that's, again, part of the circumstantial evidence that we're looking for to tell us that this is a real artifactual defect, especially with all this inflammation in here, rather than a sectioning artifact and something due to histologic processing. So we'll take a look in here. And again, we see when we look up close, we can see, so here's the normal junction, and we see that bright pink line highlighting that basement membrane, and it's cruising along, cruising along, cruising along. And now here it sticks down, it's tightly adhered to the dermis, and that epidermis, those basal keratinocytes, are peeling right off. So that's what we're looking for with this stain to tell those two apart. So this is a very interesting case, and it helps to have all the history as well about the sibling being affected, knowing the young age of the animal, the areas affected, and you just see how bright pink this is. That's what we're looking for with the PAS stain. So this was just a really beautiful case. I was very excited about this, and I thought this might be fun to share. Again, just look how beautiful that is. It's really gorgeous. Of course, I'm always conflicted because the prettier it is usually for the pathologist, usually the more unpleasant it is for the clinicians and the pets. So I do feel conflicted about that. So anyway, we just see, you know, that nice normal junction, and then like along here where it's on the bottom. So we do have a few areas here with the basal layer, but they're not quite tombstone appearance the way you would see with pemphigus vulgaris, and it's not consistent. So it's another thing to look for with pathology is sort of general trends and consistency, and is it something that's provable, repeatable, and really looking for patterns. And we can take a look here in the non-haired skin on the paw pad. We have some of this separation here as well. And you can again see that bright pink along the floor of that bulla. And again, we have a couple of leukocytes in there, a little bit of fibrin. This is just ink from when the lab will ink the specimens to identify which punch came from where. They'll mark them different colors, so that's something we ignore. But just this beautiful separation affecting the paw pad as well. And you can see in different areas, it's just these smaller separations that are a little less dramatic than in the haired skin. But just really beautiful example, an unusual case, something that at least I haven't seen very often, and was very excited about. And so I'd love to know if you guys have had cases of this, or if there's something else you're seeing, or if you have any other tips. I love when people share their cases as well. I think it's a lot of fun. I think even if it's the same condition but a different presentation, it's always fun to see that. So we just see more of these areas of separation where it's starting to lift off. So this is something else to keep in mind when you guys are taking biopsies. Certainly it's helpful to capture different areas in the ulcerated areas, but it's really good to capture things when it's right at the margin of where that ulceration is happening, right at the edge, because that's really where the action is at, and that's the most helpful and has the highest diagnostic yield for the pathologist. Versus if you were just to have the completely ulcerated area, if we didn't have the epidermis up above it, that's something that we really look for to help make a diagnosis. So I will show you, I hope you guys are able to see this. So let's see, that's a different dog. This is a case that we just looked at. So this is a clinical photo. This is a picture of Aggie's paw with the ulceration. And you can see it matches up pretty well with what we were seeing, where the epidermis was sloughing off and lifting off. And I just have some more pictures here that show that bright pink eosinophilic appearance. And then with the material there in that space. And you can just see with this hair follicle, it's just all the epithelium, not even the superficial epithelium is affected, but even extending down into the follicular epithelium. Even that is pulling away from the basement membrane and the dermis. It's zipping all around. Okay, so just some more pictures of that just to show. Again, you can just see the PAS is really lining that floor of the vesicle. I could just keep looking at this. So, all right. So there's that case. All right. So let's take a look at another case that I think was fun, and I'll tell you, it's a common condition, but in uncommon species. So this I'll just tell you, we won't make it too much of a mystery. This is a 10-year-old female spayed mixed breed dog. This is another paw pad lesion. And just to give you some history, this dog, she was adopted when she was about 1.5 years old. She'd been given up by her owner and in August of 2019, and she had a cut at that time on the bottom of her paw. So August of 2019. And then she'd been treated, curiously, with a hyperbaric chamber, and apparently the new owner felt that that had helped the paw to look better. And then she just had this ongoing lesion affecting the paw. So now this brings us to 2021. So close to 2 years, this lesion has been dragging on this one paw. She had some gooey discharge, all sorts of bandage changing, tried tons of different medications, nothing was working. So they went to a dermatologist who took biopsies of the paw, and I saw this, and I had to check multiple times to make sure, okay, is this the right patient? Is everything labeled correctly? Is everything from the right place? And I love this client. She submits awesome clinical photographs, and I love that, because it's so helpful to have the clinical photographs to correlate with the histologic findings, because that can really help from the pathologist perspective to really increase our confidence level in an interpretation, or our confidence in how we rank the differential diagnoses. And this one, we were able to get a definitive diagnosis, but I've not seen it present like this before. So already at low power, we can tell there's a whole lot of blue going on. So she's 10 years old. So, you know, certainly you might start thinking, oh, what about lymphoma? Okay, certainly a possibility. So let's take a closer look. So we've got a whole lot of blue. The whole dermis is affected, wall to wall, superficial to deep, edge to edge. There's an infiltrate of some sort. So we have something added. Is it inflammatory or neoplastic? That's sort of where our next question becomes. So we do also see with part of the epidermis, it's cruising along. It starts to get a bit thinner, and then it disappears. So it becomes ulcerated. So then let's take a look. You know, we've got some serocellular exudate on the top. And then just like before, we saw with the other dog, we saw that there was some granulation tissue beneath the area where there was that loss of the epidermis and that separation with the bulla formation. So this is a really nice example of granulation tissue, because when we look close, so these plump cells here, these are the endothelial cells. And again, you can see they are like perpendicular to that surface. So that's nice when we see them tracking along perpendicular, okay, granulation tissue. And then what we see parallel or horizontal with the overlying surface are all of these fibroblasts. These are somewhat spindle-shaped cells tracking through, they're making collagen, and they're helping to heal this exposed tissue. And this is part of the healing and regenerative process. And then there's a whole mix of inflammatory cells in here. So we've got plasma cells and lymphocytes and some neutrophils. And so let's keep cruising around and see what else we can see. So in the epidermis here, this is a beautiful example of spongiosis. So do you see all these little pink spicules in between the keratinocytes? These are the desmosomes that hold them together, like when we had before this crumbled. As they start to loosen, you start to then see like the spicules in between before they separate. So you can see those spicules, and so that's spongiosis. That's edema between the cells. You can also get edema within the cells, intracellular versus intercellular edema. So we have some spongiosis. We have a bit of exocytosis of some of these inflammatory cells, but it's looking very mononuclear. Not seeing a ton of neutrophils. You know, there are some certainly mixed in, but what's really interesting is that there's quite a few plasma cells. They've got this fried egg appearance, this eccentrically placed nucleus. They've got a little bit of the Golgi ghost, that perinuclear clearing. Plasma cells are sort of most famous for having this, but you do see this in other cells. I see it a fair amount in mast cells sometimes, depending on how well granulated they are. Other cells can do that and mimic that, but it's something that plasma cells in particular are really known for. So there's just a lot of plasma cells in here. We do have a little bit of pigmentary incontinence in here as well. So a touch of that, but just tons and tons of plasma cells. And then look at this. Look who showed up to the party. This is a Mott cell. It's filled with Russell bodies. This is all the globulin that's packed in there. I know some people, you probably have heard them referred to as constipated plasma cells. Very juicy description. So then we have maybe some hemosiderin in here. But these plasma cells and Mott cells, so that tells us chronic antigenic stimulation. And you know what? If I saw this in a cat, I would say, oh, plasmacytic pododermatitis. And so that's why I was doing sort of a double take and really, you know, double, triple checking that this really was from a dog. And so let's just keep looking and see if we're still seeing that elsewhere. Of course, you know, one of the other differentials could be something like epitheliotropic lymphoma, but we wouldn't expect to see this mix of cell types, and you really wouldn't expect to see plasma cells. These are more from like a B cell lineage, and usually with epitheliotropic lymphoma, that tends to be more T cells and epitheliotropic. And this is all very deep. Certainly some lymphomas can have extensive diffuse involvement. You can have non-epitheliotropic lymphomas. But what we're looking for here is this whole mix of different cell types. Certainly inflammatory lymphomas are something to keep in mind as well, but there's not really much in the way of mitotic activity. Maybe a couple of eosinophils mixed in here. But what's so interesting is just these plasma cells and the Mott cells. And so these can extend quite deep, and really this looks very similar to what we see in cats, just gobs and gobs of plasma cells. So I read this out as lymphoplasmacytic pododermatitis, but in a dog, it's, I guess, rarely reported. Obviously, it wouldn't be associated with FIV. In a dog, I don't know if there's something else it could be associated with. We've also got some serocellular crust and these are some lakes of serum on the surface. If I recall, I think there were some clusters of bacteria as well. And so I read this out, and then the dermatologist sent me some follow-up pictures about a week later, and she said the dog was responding well to treatment and for lymphoplasmacytic pododermatitis, and finally was starting to look better after all this time. So I was so happy and just over the moon with that. And I have to say, I have never seen a case of this in a dog before. This is the first time I was really like, yeah, that's what I would call this. A convincing case of it. So I thought this was very exciting and unusual. These clear spaces here, these are lymphatic vessels. You can see there's almost nothing in them. And so that's just something that you see sometimes, particularly on paw pads or with inflammation, you'll see some dilated lymphatics. If you see them with tumors, of course, you always start thinking about lymphovascular invasion. But let's pull up our picture here of Adler. So here she is with her little booty on her little paw. And then this is one of the photos from before her biopsy. And you can see, you know, it almost, if you use your imagination, looks a little bit like what you might see with plasmacytic pododermatitis in a cat. That paw does look a bit swollen, a little puffy. Certainly I would consider a plasmacytoma on the bottom of a dog's paw as well, but the plasma cells look very different with plasmacytoma versus plasmacytic inflammation. And I can pull up another example of that. But then here we're looking at the histopath and just lots and lots of plasma cells. They're just everywhere you look. And then this was some of the serous-cellular crusts. There's some cocci bacteria enmeshed in there. And then this, I believe, was after the biopsy, and then was starting to show some response to treatment. And then I think this was another after photo. You can see the sutures from where the biopsies were taken. So she was starting to show some improvement, and I just thought it was very exciting and unusual. So a common diagnosis, relatively common if it were a cat, but in an uncommon species. And so I just thought that was really interesting and fun to share. So that's what I've got. I'm not sure what else to do. So please let me know if you have any questions, if you enjoyed this, or if you have feedback. I will continue to work on my getting more familiar with the technology, and I apologize for any mishaps here, but hopefully you enjoyed this and this was fun. I would love to hear your ideas, or if you guys want to share cases, we can do this together, or if you want to go through some stuff together or do something as mystery slides. I am open to any and all suggestions, and I want this to be fun and enjoyable, and I look forward to seeing you again soon. All right. Bye, everyone. Take care. Have a great weekend.